I'm going to introduce our next speaker. Dr. Shannon La Cava is a clinical psychologist specializing in psychosocial oncology and is the Chief Clinical Officer and Director of Programs and Research at Cancer Support Community Los Angeles. Her research interests focus on multidisciplinary engagement to address health inequities and support the psychosocial needs of pediatric, young adult, and adult patients and caregivers. She is the current chair of the Health Equity Committee of the American Psychological Association, an active member of the American Psychosocial Oncology Society. Dr. La Cava has engaged as a community advisor and co-investigator in research collaborations with American Institute for Cancer Research, Kaiser Foundation Research Institute, Providence St. John's Health Center, Cedars Sinai Medical Center, and UCLA Center for Cancer Prevention and Control Research. Please welcome Dr. La Cava.
Thank you, Myra. It's so good to see you. Thank you for hosting our event this year. And it's wonderful now getting to see all of those that are participating and watching. So hello to all of you. Thank you for joining. So today I'm going to be talking about thinking outside of the box. And this is really about utilizing multiple systems of partnerships in a way to create models of cancer care. And I am just very honored to be coming after the conversation that Dr. Jennifer Kelly started, which really kind of laid the groundwork. And I think sometimes the what can we do might be how can we collaborate and how can we work together to do more. I have no financial disclosures. So I'm going to start with telling you a little bit about me, and this might be a little unusual, but bear with me, and there'll be some reason to this as we get on to the top. So this is me when I was young. This was the first day of kindergarten. I had this idea that I was going to take the bus. I was an only child, and I felt very independent. I think that somewhat sticks with me now, but I was really excited to take the bus. Only realizing later the impact that may have had on my mother and my family, because this was one of many series of the bus driving away. But that was part of my kind of early life. Moving on to my awkward years, this was me, I think it must be 7th grade. I was on a Zoom call much like this actually, and I saw all these text messages coming through and I couldn't figure out what was going on. And I realized that my husband had found this photo and shared it with all of our family on a text chain. And this has been now named my Spicoli years, if you have watched any Fast Times at Ridgemont High. And some awkward years continued. This was me with sporting my broken arm just a couple weeks ago. So that might be puzzling why I showed you those photos, but we're going to put those together as we get into the presentation. Some of the learning objectives today are to design and utilize a positionality statement, to conduct research or health equity assessment to support your own research and support your own practice, to list values of partnering with multidisciplinary teams and other community-based organizations, as well as utilize existing models of collaboration to create effective partnerships. So we'll take a look at some community partnerships. What we're going to be talking about today in terms of partnership or some opportunities to collaborate are looking to work within disciplines, across departments, even across institutions. And we'll highlight a lot of community-based. Being here as the Chief Clinical Officer at the Cancer Support Community Los Angeles, we are part of that community-based arm, and I'm excited to talk more about that. I also had the great honor to participate in the Health Summit last year, and I think today's a good day to kind of start where I left off the last time, which was with this and how we can create an evolution of community partnership, utilizing a lens of health equity to collaboratively engage communities, revolutionize supportive care for families facing cancer. And to do all of this with inclusive targeted support to enhance the value across the healthcare system. Looking first at community-based participatory research, this gives us a great way to understand how research can be conducted within the community, but not just within the community, at the community's need and with the community's involvement. Community-based participatory research is a partnership approach, which it involves the researchers and the community stakeholders to engage together as equal partners across all aspects of the research process. Looking at an illustration, this helps me to really identify the core components. So these are what CBPR is really made of. And I know this is really small, but it's looking at accessing community strengths and dynamics all the way to designing and conducting interventions or policy, to disseminating those research findings and translating those research findings into programs. But the piece I really want to highlight today is in the center, and that's maintaining, sustaining, and evaluating the CBPR partnership. So with community-based participatory research, the partnership is in fact part of the research and part of the goal. And they've broken it down to different elements of the group dynamic, including group membership, equitable participation and communication, establishing norms for working together, developing trust. And remember that one, we're going to have that threaded through our talk today. In addition, selecting and prioritizing goals and objectives, identifying community strengths and concerns, looking at leadership, power, influence, addressing conflict, and establishing steps if conflict were to come up, what would you do to address it? Strategies for working across diversity, and partnership assessment. So this isn't a one and done. We are going through this at the beginning, and you're continuously evaluating the way that you work together in order to have this research be successful. So taking that and looking at how partnership may apply to our work relationships and our academic relationships and our mentors and esteemed leaders, I want to look at it that way. So think of a mentor. This is just a little activity that we can do. Think of somebody that you look up to or that assisted you early in your career. And even if you're at the top of your game right now, really think back to those that really helped you lay the groundwork for where you are today, those that you felt you wanted to emulate. So as you think about this, what qualities come to mind? How did you feel when you were working with this person? Think about the characteristics of this person that resonated with you. And maybe you have already started to utilize those in your own work. Maybe there's some, as you consider now, that you'd like to recall fondly and think, how can I incorporate that into my work? What attributes do you hope to emulate? And how can these characteristics support your collaborative goals? Are you thinking of characteristics of somebody being a good listener, a sounding board, being flexible, valuing diversity of perspectives, being non-judgmental, being knowledgeable? Are they able to give constructive feedback? Were they honest and candid? Are they able to network and find resources and act as a model? So thinking about that, thinking about how you consider a mentor of your own and how you want to be a mentor and leader, I'd like to look closely at some data that came out of an article, Park et al. This came out in 2020, and the article was Co-Creating a Thriving Human-Centered Health System in the Post-COVID-19 Era. So this is really coming out of how did leadership respond? How did leadership pivot and learn from the COVID pandemic? Really looking at and focusing on workforce well-being and burnout prevention and how that's influenced by the organizational and leadership practices. What do we have in our control to alleviate some of that? Post-crisis leadership actions often define organizational culture for decades, and it can lead to long-term stress, or how we respond in trauma or to the COVID pandemic can also lead to post-traumatic growth. Unprecedented opportunity was seen to prioritize organizational structure. And strategies that they identified that were successful for organizations and businesses was to attend to the structural and technical breakthroughs. I know we were not on Zoom for our conferences in the past, right? So there's something with technology that we can lean in towards. Focus on the relationship and cultural leadership strategy. What does the culture look like? And what culture are you creating when you have a collaboration? Because you're doing that now with a partner. And maintain presence and creativity to connect a team. So having that lead to maybe entering into a partnership, I like the idea of a closed mouth is never fed. And I heard this kind of early into my return to academia and going back to school. And it gave me the strength to be able to reach out and ask for help, reach out to ask for mentorship. And I continue using this because this is how I think we can work together. We can collaborate. We can get out of our comfort zone because we can have the ability to ask. So coming out of the American Medical Colleges, and this is a nonprofit that identifies itself as the National Center at the intersection of community development and health. They're looking at the value of partnership designed with sharing expertise and resources and responsibilities with communities for achieving shared goals. So with is really important here. And that's done so through trust, respect, humility, and for mutual benefit for both parties. This includes community-based learning, engaged research, and healthcare delivery, all to ensure the health of all. And this goes back to, hopefully you were able to attend Dr. Kelly's talk of not just the social determinants of health, but the definition of health equity to really make sure that everyone has access to being healthy. The goal of the medical schools and teaching hospitals that are affiliated with the American Medical Colleges is to work to ensure that the health of all is ensured by collaborating with communities across clinical, research, and educational missions. So with this, I just started kind of Googling for fun, and I thought, okay, let's use the idea of with. But if you do a very simple Google search, you find out with is defined by the example of a nice steak with a bottle of red wine. So they went right to drinking. I thought that was interesting, so I took a little deeper dive. This is Merriam-Webster's definition, and this really talks about being a participant in an action. And I think that's a great way to lead us into conducting a health equity assessment. This is an actionable step that I'm excited to share with each of you, and it gives us a tool that we can use. So the health equity assessment tip sheet, and this can be put into the chat so you will all be able to access this without having to copy down the URL code there. But this is also coming out of the American Psychological Association and the Health Equity Committee. So last year they were tasked with Equity Flattens the Curve and being able to address that idea of equity, putting together this. So this is for all mental health providers as well as all individuals in healthcare in general. And this is setting the stage for equitable partnership. In terms of those actionable items, it's looking deeper into our own personal and institutional practices and potential biases. And the tool is to self-assess health equity in the practice and research comes out of the Health Equity Committee. So looking inward, trying to reduce inequity and bias within your own practice, uncovering those policies and procedures and potentially decisions, what is existing that can be changed to make a more equitable provision of care. And there's some quick tips. The conditions of the environment where people are born, live, learn, work, play, worship, and age. This is the social determinants of health. Dr. Kelly went into a little bit more detail in explaining them, but all of these come into play. So being aware of the social determinants of health of those that we're trying to reach and provide services to, and to also to adjust and modify how we provide services, I think is a very unique way to look at this and what the control that we have in being more equitable. So again, looking at the sources here, looking at health equity and the person's overall health and quality of life and how they're influenced by social determinants of health. And some data here that really kind of shows that the outcomes in terms of economic loss, lower rates of education, higher rates of healthcare expenditure, unemployment, that these are possible inequities that we need to be aware of as we design our practices. This also shares some questions that you can utilize to uncover some of your own practices and internal structures that could be reshaped, redesigned. So questions in terms of equity, diversity, and inclusion in your staffing, educating on health equity issues, community and professional partnerships, which is a lot of what we'll talk about today. Even location and proximity to public transportation and the hours that you're giving services out to your clients and to your patients. How can that be changed? So in terms of quick tips, there's like, these are just 5 to really start looking at your organization's role in achieving health equity. The first tip is planting the seed and committing. And hopefully your attendance today is that seed if you haven't even gone further. But also self-reflecting as an organization, engaging with stakeholders and communities, partnering, collaborating, getting out there and seeing what the needs are, putting a plan in play, putting it in paper, implement it, and continuously monitor. There's fluidity in these steps, so we can always continue to learn and grow. So now that we've looked into our personal practices, we can imagine how we present ourselves and put this puzzle together from earlier, my photos that I shared. And we're going to do so by looking at positionality statements. So positionality statements, it is a world view, if you will. Where are we coming from? It is informed by an individual's values and beliefs, shaped by gender, sexuality, historical and geographic location, ethnicity, race, social class, religion, faith, spirituality, political allegiance, disability. I mean, I'm going through a lot here, but all of these make us who we are. And this can be something that we can present as ourselves and also to others in terms of how we provide research and how we provide programming. In research, position is how a researcher might adopt within the project. What position are they taking within a project? It influences how the project might be conducted. It might influence the outcomes and the results. So there's an awareness there. Be aware of how positions may impact the participation in research projects or in settings where we're giving more of a service delivery. The influence of insider-outsider standing, acknowledging advantages, disadvantages, implications for the process of data gathering and interpretation. And if you look at this list here, you can see that it's integral in qualitative research, but that's also something that can really be utilized in terms of how we develop programs and collaborations for service delivery. So a researcher or an individual's positionality is not fixed. It's a reflective practice in articulating one's positionality, and it may assist in becoming a better researcher. I would go on to say it could even influence how we become better at collaborative partnerships and how we become stronger within our community. So my positionality to share here is that I'm a white, heterosexual, cisgender female, come from a middle-class background. You saw a little bit of my background. I have access to economic resources and a high level of education. I'm doctorally trained, and I work and choose to work in the nonprofit sector. In terms of my perspective, there's some additional components to who I am. This is the lens I use in my professional work. This is me on paper, but I'm so much more, and I bring that to my relationships and my collaborations. You saw a glimpse of that at the beginning of the presentation. So using the concept of positionality statement when stewarding relationships, what that can look like is applying positionality statement to authentically engage in the community and with your community partners. Build complementary partnerships and learn and grow from one another. So this is just some information that actually comes from LinkedIn article, and this is a human resource professional. I wanted to get the idea of human resources, tying together those factors of building collaborations and being leaders. And this really comes to light right at the top is the idea of trust. So as a building block for collaboration, incorporating trust, vulnerability, communication, self-awareness, and commitment. And that can lead to change. It can lead to information sharing. It can lead to dynamic listening, being empathetic listeners, hearing one another before moving forward. Negotiation and flexibility can also be included. So you can see how authenticity and transparency can support community engagement and collaboration. Rather than coming in as an expert, come in as equals and build something together. Knowing our challenges and being open to share, to learn, and to gain insight. Now, in terms of applying research standards to collaboration, so I just really want to quickly draw from the standards that we have in place that are built into research designs and see how that might influence how we can build collaborative partnerships and community engagement. And to do that, I'm going to look first at the human subjects research guidelines. So this comes from the Belmont report. So if you have any experience with research, you have probably done a human subjects training. And this comes right from there, the ethical principles and guidelines for the protection of human subjects in research. And this was established in 1979. So the respect for persons requires researchers to assure autonomy and protect those with diminished autonomy, allow those who can to make informed choices about taking part in research, and by instituting added protections for those who do not have the capacity to decide. In diverse communities, this can only be accomplished when information is tailored to the subject's linguistic needs, it's comprehensible, it's delivered in a culturally congruent manner. So considering that respect for persons as it's laid out with research, how would that influence how you might incorporate collaboration? How might you partner with somebody in the community or another agency, a leader in the community, a church group, another healthcare provider? There's a lot of ways that you can consider this. In terms of beneficence, this requires favorably balancing the risks and the potential benefits for participation. Risks including physical, emotional, economic, stigmatization, confidentiality. So weighing those out to how the benefits of the participation in research might be for that individual. And I think this applies also to how we incorporate and start to embed services into the community. Researchers need to engage community leaders in the process of estimating risk-benefit ratios to gain full appreciation for how participation might affect individuals participating in studies. And this is also true for what we do with collaborative services. And then looking lastly at justice, this is for an individual requires fair recruitment practices. Social justice requires decisions be made by researchers in light of the ability of certain ethnic and economic classes to bear added burdens of research. Disadvantaged groups should be protected from being asked to participate in research for the convenience or for the socioeconomic status. So consider how this also guides the community collaboration efforts. And use caution. Caution is required in research. Trust should be a first step for interventions and practices as well. Additionally, when conducting research with diverse communities, we're looking at how do you involve community members in decisions about key aspects. This is promoting feelings of ownership within the community, maintaining public accountability and transparency, assuring appropriate ethics oversight, and again, building that trust. And this is also threaded through when we introduce the community-based participatory research and how these elements can be considered in partnership development. Also, coming out of how research can be conducted with diverse communities, or all research for that matter too, is how we disseminate the results. And this is to really make improvements in public health. So when working with communities, we want to make sure that we share the findings with stakeholders within the community. We can get literature into peer-reviewed journals, but we can also disseminate it through educational programming. We do a lot of programming here at CSC Los Angeles in order to assist those that are either conducting research in the hospital system throughout Los Angeles to get their findings, their outcomes out to the public, but also to use as a recruitment tool and to educate the public prior to starting research. So there can be some buy-in and some trust building on both sides. Okay, so now to just give some samples of existing evidence to support collaboration and partnership, and this comes in the mental health area as well as oncology care. So this comes in this is a phenomenological study from medical providers. So this is outside of cancer, but it does have the utilization of medicine as well as mental health. For this study, 18 medical providers from diverse settings were interviewed about their experience in collaborative healthcare settings in which mental health services were integrated. And using the phenomenological model and that approach, they identified 5 themes that had emerged that served as benefits and or barriers to the delivery of the collaborative healthcare. One being time and resources, proximity of access and collaboration, collaborative mental health literacy, stigma, and finances. To dive a little deeper, stigma was the impact of mental health stigmatization as a barrier to accessing care. So they recognized that as a theme. However, the medical providers identified that working in collaborative health settings reduced the barriers. It gave immediate access. And this, as a follow-up to Dr. Jennifer Kelly's talk, was really embedding services where people want to go, was a recommendation that came out of how to make more equitable healthcare services available. So this is a finding that also supports that, is to embed those services. Benefits and barriers were linked so that the benefits mitigated the impact of the barriers on the respective themes. Two exceptions were the barriers related to availability or scheduling and the other financial barriers. The recommendations coming out of this study was that healthcare settings that offer multidisciplinary cohesive care demonstrate improved treatment continuity and patient outcomes for both physical and mental disorders. Collaborative healthcare approaches improve provider and patient outcomes and access across diverse clinical settings in an overburdened system. So the collaborations actually created more access and were able to be conducted even in systems that were overburdened. And mental health services should be offered in the same location as the patient seeks out medical treatments was also a recommendation coming out of this study. What that means in terms of what we do here at Cancer Support Community is also the idea of collaboration and how can we ensure delivery either on-site or off-site, and how can you build your own services within your system for mental health. Another study to look into, and this does look at oncology in the area of pediatrics, was from SuperSibs. And I remember using SuperSibs, and we still have that as a resource here for our pediatric clients and their siblings. But it's a national organization, it's a nonprofit, and their mission is to ensure that siblings of children with any type of cancer are supported, honored, and recognized so that they can face the future with strength, courage, and hope. So although most community partner research occurs at a local level, the community can encompass a geographically diverse cohort. So they're identifying diversity and community as this large geographic area of individuals experiencing childhood cancer. So this was a partnership that they developed across multiple healthcare systems. And the lessons that they learned were, one, to realize a shared mission. So they utilized what they called a sibling research advisory board. They partnered with multiple academic institutions over an 8-year partnership. The cohesiveness was fostered by intentionally creating a culture of collaboration. And their second lesson was to balance research and service responsibilities. So the involvement in SuperSibs was neither contingent nor related to the research enrollment. So individuals could participate in the research, but it did not hinder if they chose not to be in the research, that they could still utilize the resource and the service. And then 3, to ensure sample representativeness. So recruitment through community organizations may reduce the degree to which a sample resembles the broader population. So a second question that they identified here in terms of also what steps for future research was whether families who enroll in the research resemble those who decline. So in terms of community groups or researchers seeking to establish partnerships, they're included to do these recommendations from the SuperSibs partnership. And that's to identify partners committed to establishing empirical support for community-based initiatives, develop shared goals, use goals to inform a partnership mission for short and long-term objectives and strategies, and to frequently assess progress and modify their approach if needed. And in the nonprofit world, this looks very familiar, to identify sources of ongoing financial support. So did you hear some threads that might have been similar to the community-based participatory research and to how partnerships can be developed and continuously monitored? And then, yes, looking back to that CDPR, we can see that community-based participatory research projects are used to inform action within the community, and that the findings should inform community efforts and incorporate change. So coming from those 2 projects that we looked at, and then looking here as how the CBPR recommends for dissemination, we want to look a little bit further into coming from these tenets of CBPR into actual dissemination and implementation and what that means. So dissemination is an active approach of spreading evidence-based interventions to the target audience via determined channels using planned strategies. Implementation is the process of putting to use or integrating evidence-based interventions within a setting. And then a final area here to consider is reach. And that's the ability of a program to engage its ultimate target audience. Are you reaching those that you're hoping to reach or you're expecting to reach, both in terms of quality and quantity? And this is going to be a great influence to public health and make an impact on public health if done correctly and successfully. So these each come from the Dissemination and Implementation Research in Health second edition. And I'm going to dive down a little bit more into this book. And this is the authors of Kirshner et al. And these are the different strategies for implementation. So to go through quickly, it's to use and evaluate integrative strategies, provide interactive assistance, adapt and tailor the content, develop stakeholder interrelationships, train and educate stakeholders, support clinicians, engage consumers, utilize financial strategies, and to change infrastructure. That is a lot of information, and I do encourage you to look back at the dissemination information research findings and information. But for the sake of our talk today, I'm going to focus on developing stakeholder interrelations. So here are some points, and these are expert recommendations for implementing change. This came from the EPIC project. And to give a little detail to each of these, I think I lost my slide. It's to develop academic partnerships, partner with a university or academic unit. I would say that you can add a community-based organization or any kind of organization within the community that supports the population that you seek to work with. Identify and prepare champions. Involve executive boards, involve governing structures. There's board of directors, there's medical directors. We could add the idea of community-based advisory boards, professional advisory boards. We also have a Cancer Equity and Diversity Committee. Obtain formal commitments, get MOUs, get contracts, make these agreements formalized in terms of your partnerships. Promote network weaving. Build on existing relationships within and outside of one's organization. So promote information sharing and collaborative problem solving. Work together. Recruit, designate, and train for leadership. This is, you can lead change. And we looked at that. We looked at even how post-traumatic growth can be really influenced by leadership, especially coming out of COVID. Use advisory boards and work groups, and that can be a way to engage multiple stakeholders to provide insight and guide implementation, and to visit other sites, see what's successful out there, and learn from each other. And I would add too, that's also another way to identify another partner and steward a new relationship. With that, I'd like to take you into the collaborative research and practice that we have here at Cancer Support Community in Los Angeles. So this is Cancer Support Community. We look a little different now. We have been very virtual, and we're just starting to have some in-person services return. But this is what it looked like coming into our community space. And all of our CSEs and Gildas clubs across the country and in Canada, and we have 4 international offices actually, they have that same mission and model to empower with knowledge, to strengthen with action, and to sustain with community. And I welcome you to come and visit if you're local, or if you are not in the Los Angeles area, find a CSE or Gildas club close to you. In terms of the work, this is kind of a brief overlook, a very brief overlook at the services that we have in play. And we look at it sometimes across different pillars, those being our emotional support, which is group support, counseling services, educational workshops, healthy lifestyle classes like Qigong or yoga, or have Nordic walking in the park, many mindfulness and meditation classes. We also have social activities and a child, teen, and family program that mirrors all of these areas. What's not on here is our resources and how we can be a resource as well as share resources. So we have a long list of other community organizations, other hospital services, other nonprofits that do similar work, that are like-minded, like-missioned, and how can we share that? So if somebody contacts us, we hope we can fit their needs, but we also have many other opportunities for them to get engaged and get support. And to share a little bit about the internal culture, we spoke at the beginning on that leadership piece and what it was like to pivot during COVID. And this slide actually came from a talk that I shared kind of early on in COVID. And this is when we really recognized who we were and how we could be internally as a staff. We are a small administrative staff. There's usually 7 or 8 of us, and we have about 25 in total, and that's inclusive of our licensed mental health providers across disciplines of psychology, marriage and family therapy, social work. We also are a training institution, so we have those same disciplines that are trying to get through their graduate programs or into licensure. And what we recognized during COVID was also the need for us together to promote acceptance and to encourage flexibility, to welcome vulnerability and to model resilience, and us being able to work together and to have that as an expectation for ourselves was a way that we could set up and design our expectations for those that use our services to be more flexible when those who are accessing our care might not be able to be here every day, might have hiccups with their internet. How do we look for grants to offer internet and hardware tablets? How do we think differently? As an example here to also highlight leadership change in the promotion of post-traumatic growth versus that stress, we were just going into a clinical team meeting. So it's much like a supervision or consultation meeting that we have with all of our licensed and unlicensed clinicians. And we were just going into our meeting around the same hour of the January 6th riot. And that was a lot of stress. There was multiple inputs of information, a lot of technology happening. There was TVs were on and phones were ringing. And if there's notifications on your phone, there was a lot happening that day. So it was to not go into our typical meeting, but to make space. We did a breathing exercise and a guided imagery exercise together to center. And we had the ability to knock off that meeting. If you did not want to attend, don't. Do what you need to do for you right now. And we actually all stayed in the meeting after doing that imagery and breathing exercise. And we were able to actually support each other when this was happening. And I think that is a really great way to illustrate just how that acceptance can be. We're in this together through the pandemic. And if you were at Bill's talk, you saw that Bill has had personal experience that led to his being a provider of care for cancer. So we can't take ourselves out of it, but we can really start modeling these sorts of healthy internal structures and cultures in the way that we do our work. And this applies to how we collaborate with others. In terms of external collaborations, we co-brand support groups and services. During COVID, we even did more educational presentations. We had a wider, more diverse audience because we didn't have to be in person. We were able to join hospital team meetings. We did conference presentations across APOS, the SoCal Women's Conference. We had English and Spanish presentations there. We recently did an equity, diversity, inclusion clinical trial training, and this was a global conference. And these are elements that we would not have access to if we did not think about how the virtual technology can support our collaborations. Although I am looking forward to doing some in-person work, and I've been to a couple of conferences recently in person, so I think there's change happening. And then lastly, you are here at our Health Equity Summit #2. Last year was the establishment of our inaugural Health Equity Summit, and that came out of the ability to kind of share what we know in a way to give service and education, but also as a fundraising arm to the work that we do here at CSCLA. And that also came out of thinking differently and collaborating differently. In terms of external collaboration, we also increased our attendance. We had targeted and specialized programming. We were able to reach more people because they did not have to be here. Prior to COVID, I remember having a very small group of people for a myeloproliferative neoplasm event. And we had about 10, 12 people in there. And someone said to me, this is the first time I met somebody with my same diagnosis. And thinking about how that can shift the use of technology and having many, many people join together and being able to connect with others like them. We created a SoCal initiative, and that's how we work together throughout our SoCal area here. I have 3 other sister sites. So we work together. We are CSC South Bay, CSC Pasadena, CSC Valley Ventura, and CSC Los Angeles. So how do we collaborate? We also recognized the strength of programs in virtual space, like I said, and that was utilizing a video library, which is growing by the day. And at the very early part of COVID too, it was kind of contraindicated to have minors on telehealth. So we created videos with wonderful activities, therapeutic activities that could be done with the family. So how do we think a little differently? This is just a snapshot, an overview of our strategic plan that we have here at CSCLA, and this is 2022 through 24. And I'm just going to highlight the large goals, which were to expand impact, build capacity, engage communities, and be fiscally responsible. Looking at the engaging communities, we have the goal here to increase access and delivery of high quality, high value services and educational programs to communities in need. And the strategies that we've developed here, you can see, I just wanted to pull out two really important pieces, which is to steward relationships and to implement justice, equity, diversity, and inclusivity framework across all of our program development and administrative operations. That's included here in this goal, but it is threaded through the entire strategic plan. So what that looks like, engagement of a community advisory board. We have a professional advisory board for those that are leaders within oncology and supportive care, but also our Cancer Equity and Diversity Committee. So this is individuals throughout Los Angeles that can really share their voice to the work that we're doing. And we're also proud to be participants in the Cedars Sinai Community Advisory Board, City of Hope Community Outreach and Engagement Community Advisory Board, as well as the UCLA Johnson Comprehensive Cancer Center. They have a Clinical Trials Equity Advisory Committee. So these are ways that I encourage you to either lead and have an advisory board of the work that you're doing or participate in another's. This is a quick visual of how we think about our program delivery across different populations and how we can ensure that we do not have gaps. We want to grow in these different areas. And our HEART program is healing equitably through action, resilience, and teamwork. This is actually just the way that we consider how to partner across Los Angeles and beyond, with a list of some of our current partnerships. And then to finish up, I just want to show you some of the different work that we're doing collaboratively. So this is Sister Friends, and Yolanda Whittington is actually going to be on our panel, I believe, tomorrow. She facilitates this group that we do collaboratively through Sister Friends, and she's the founder of Sister Friends. She's leading the Black Women Living with Cancer group. And this is online, and we have a goal to also offer something in person at Sister Friends. Frankly Speaking About Cancer is a evidence-based platform for multiple different types of education programming. It comes out of our headquarters. And Frankly Speaking About Cancer, we did a cost of care. This was in Spanish with one of our providers, and we have a new program coming soon that's going to be in Spanish. It's going to be in person at White Memorial Hospital Medical Center, as well as online for those that can access it that way. More to come. We're very excited to be partnering with our sister affiliate, Gilda's Club in Madison, Wisconsin. And this is also through some sponsorship from Grit Health. This is our young adult game night. So out of requests from individuals accessing our young adult services of needing more social time and social engagement, we created this game night, and it's incredible. We have some special guests coming soon. This is a recent event. This was at the zoo, and it was wonderful to be in person. And we are very grateful to Dr. Aura Cooperberg and Shu at the Adolescent and Young Adult Cancer Program at USC for the invitation to participate in their family event in Zootopia. This was an event where we were able to come, myself and two of our clinical associates here, to provide a therapeutic activity with the children and teens. Digital Sherpa, you might hear more. This is growing and coming soon to different areas of how we can link those that are in volunteer, coming maybe from some of the universities in the area, to support those that might be in the older populations with technology, and kind of have this intergenerational training and teaching to support people in getting connected through the use of technology. We're also working with Dr. Maria Garcia Jimenez, and she has a cancer clinical trials program that she's putting together through UCLA and all of you. We're very excited to be participating in that, and this is also going to be all available in Spanish. And lastly here, this is just to highlight a recent caregiver initiative that we had, and this was collaborative not just through Providence St. John's, CSCLA, and through the gracious support of Tower Cancer Research Foundation, but it was a consortium that had leaders throughout LA that came together to design this content on becoming a mentor to cancer caregivers. So with that, I will share my contact information, and I hope you take note of this. I want you to reach out. I want to work with you. And we're very excited for the collaborations we have in place, but also looking for those that are coming next. So I look forward to hearing from you, and thank you very much.
Thank you so much, Dr. La Cava. That was a wonderful presentation, and I love the pictures and the sharing of your personal story. And I think we all have that awkward school picture. I don't think there's a person out there who doesn't. Maybe they are always wonderful at taking pictures, but I definitely have that awkward picture. So I do want to remind all our attendees that you can add your questions in the Q&A feature. But my first question to you, Dr. La Cava, is we know building trust is of the utmost importance when building partnerships. So how do we ensure that that trust is maintained throughout the process? So what happens when that trust is broken? How do you repair it, and can it even be repaired?
That's such a good question, and I think there's a few questions within that. So as some of the literature really speaks to reevaluating, continuously monitoring partnerships, right? So that I think if you're able to establish trust, which there's a lot to that piece, right? And I think is how do we come as our authentic selves into a relationship without being the expert with really coming to that collaborative and equal parts building of a relationship, stewarding of a relationship. So if you get to that place and you have this trust built, in terms of keeping that trust, I think that comes in the work that we provide and who we are and how we show up in our partnerships and how we communicate it, whether it be within a community, how we keep engagement, how we, whether it be research or service delivery, how do we really keep that engagement and listen to the community? I didn't get a chance to explain on our Cancer Equity and Diversity Committee. The name came out of, if you call it SED by its acronym, SED in Spanish, and you can probably speak more to this than I, but it means thirst. So this came from our community advisors to not just say we need people to come and help and provide resources to under-resourced areas, but we want a voice. We want to share what works in our community. We have strengths that we think need to be highlighted, and that's how we can learn. So I think having that voice and continuing the relationship that way is a strong way to keep that trust and to keep that relationship strong.
Wonderful. Thank you so much. And we have a question for you from the attendees. And the question is, what's the most important lesson you've learned from engaging in community-based participatory research?
So in terms of my lesson there, I was so excited. So it was years ago, I participated in a quick start study. And I advise any of you, if you are able to join a CDPR training, the quick start training program, if you Google it, it is a very intensive training. In the past, it was in person, a couple days here in Los Angeles and a couple days up at Berkeley. And it was a wonderful way to learn all of the ins and outs of community-based participatory research. And I put together, at that point, there was a couple of us to put together a grant. We were unfortunately not funded, but what I took from that was I used threads of community-based participatory research, and it is a mouthful. I don't think I've ever gotten to master how to say that quickly, but I've used that as how I inform the work that I do daily because of what the meaning is on who we are as we show up in our work, and also how to engage. To consider the idea of a closed mouth is never fed. How do we get out there and work together? And I think it's kind of like two heads are better than one. So if we're trying to look at an issue or a problem, I think it's good to work together and brainstorm that way. The same as how do we get the services where there's need? And I think that's looking at what can we do together, back to Dr. Jennifer Kelly's question, or how can we do it? Maybe we can do it together. So I would say in terms of community-based participatory research, it's threaded in research collaborations and as co-PI on other projects. And it is really part of how we do service delivery and how we grow our programs.
Wonderful, absolutely. And our next question asks, what advice do you have for cultivating relationships with community collaborators?
getting advice from community collaborators. I think it's just that humility, right? And I think if there's an honesty to how we engage in a relationship, and if in the thread of positionality statements of working with others that may complement ourselves, I think it's all about being a complement and what can I bring, but how can I be humble and ask and be transparent about what I don't know. I showed some awkward pictures of myself to just show that maybe we don't always have to have that perfect component of how we present ourselves. Maybe we can be, warts and all engagement and be able to model that we also trust that other person and aren't judging in any way. So I think that's how we can come into those types of relationships.
Absolutely. Yeah. And you know what, I have one more question for you. And so you had mentioned this in one of your answers that what was the saying that a closed mouth is never fed, right? And so you're basically saying ask for help, get out of that comfort zone. But what would you say to people who maybe feel like they don't have that confidence to get out of that comfort zone? What can they do to build that confidence so that they can get out of that?
Oh, good question. That's a good question. I would say, start small. Everything is like a baby step until you learn to walk, right? So maybe it's not reaching out to somebody that you've had no contact with a grand question that is really, really out of your comfort zone, but how do you make small requests? And I think sometimes even taking inventory in the conversations and the dialogues that we've had, we can recognize where we've done that already. How did we get to the role that we're in? What's our favorite thing about this role in this position? What do we want to do with it? How do we want to collaborate? And sometimes that can guide us a little bit, but start small and trust yourself. And I think the one thing that was kind of provided some comfort for me when I started thinking that way about the closed mouth is never fed is what's the worst that can happen, and not to catastrophize, but someone can say no. And thinking, okay, well, I can manage through that, right? If someone says, no, I can't make time, or no, I'm sorry, I really am not able to do your request, I can handle that. And I think the idea of making the effort to connect, it should be received well, even if the answer is no. And I've actually been really, really successful, because I will say on the flip side of being someone who I enjoy mentoring. I like being a supervisor clinically. When someone comes with a request that's really personal to the work that they're trying to do, to their professional development, and it might not be in response to a large didactic, but I just wanted to ask you this thing, or I wonder if you can help me here, or do you have any ideas about this? I'm pulled from that because that's something that I want to do. And I think if we put ourselves in that shoes and who we are and how we would respond to a question, that I think gives us the confidence to be able to make some more of those asks.
Wonderful. Yeah, that's some great advice. I know not all of us are comfortable. We do fear that word no. But yeah, I love the mindset that it's what's the worst that can happen, right? Although that idea could get out of hand, but you're right back where you started, right? If you never asked, and somebody says no, that's where you started anyway. So it's worth the risk. And we do have a participant that's asking if you could please repeat the name of the foundation, the one that was it Black Women Living with Cancer.
Sister Friends is the organization that we're collaborating with. Yes. And so that is a nonprofit that offers mental health services to women and men in the Black community. And
wonderful.
And Yolanda will be here as well tomorrow if there's more further questions.
Yeah, and I don't know, maybe perhaps if there's a website, maybe we can add that link somewhere so that people can have access, or maybe with our speaker tomorrow. So maybe please join us tomorrow, obviously to learn more about this organization and the wonderful work that they're doing. So with that, I want to say thank you so much, Dr. La Cava, for sharing your expertise in community-based